Okay, good afternoon, good evening, good morning, viewers, wherever you're located. Thank you for joining us today as we discuss this critical subject today on women and the return to poverty. This webinar is organized in collaboration with our sister center, CGC Paris, and the Women Engendering Global Affairs, an interdisciplinary international network of academic scholars and centers focused on women and gender in global affairs. We have a great panel. Kindly engage with them to get as many of your questions answered. Before we proceed, we would like you to know that this webinar will be recorded and can be accessed on our YouTube page as well as on our website under videos in the coming week. Some features have been disabled, these being audio and video sharing, as well as screen share. You're welcome to submit your questions using the Q&A feature at the bottom of your screen. The moderator will direct your questions to the panel towards the end of the session. So kindly remember to use the Q&A feature instead of the chat. Q&A. For more engaging programs, please subscribe to our mailing list by visiting our contact us page on our website, globalcenters.columbia.edu/Nairobi or globalcenters.columbia.edu/Paris. Our moderator today is Professor Yasmin Irgas. Professor Yasmin directs the specialization on gender and public policy at the School of International and Public Affairs of Columbia University and is a senior advisor to the Institute for the Study of Human Rights. She is a member of the faculty of the Executive Committee of the Committee on Global Thought and of the Executive Committee of the Institute for Research on Women, Gender and Sexuality, and co-chairs the Women, Gender and Sexuality Studies Council at Columbia University, as well as the Columbia University Human Rights Seminar. She also serves on the advisory board of the Journal of International Affairs. A lawyer and a socialist, Irgas has worked on issues regarding gender and women's rights as a policy analyst and advisor, scholar and advocate. She has served as a consultant to the international and domestic policy organizations, including the OECD, UNESCO, the Millennium Villages Project, and the New York City Commission on Human Rights. Her recent work has focused on the emergence of international markets in reproductive services, the transformations of motherhood, and the backlash against gender rights. She regularly engages in discussions regarding gender equality policies with national and international bodies. She is currently serving on the advisory board of Women Strong International, the advisory council of the Women's Rights Division of Human Rights Watch, the editorial board of the Journal of Human Rights Practice, and the editorial board of Engineer.it. Professor Irgas' work has been published widely, including in Italian, French, German, Japanese, Spanish, and Portuguese. Her recent publications include Resembling Motherhood, Take Back the Future, Global Feminism, and the Coming Crisis of the Beijing Settlement. Arguing for equality between pragmatism and principle, and Babies Without Borders, Human Rights, Human Dignity, and the Regulation of International Commercial Surrogacy, among others. I would now like to hand over to Professor Irgas to take the program from here. Professor Irgas, take it away.
Thank you so very much. Thank you for inviting me to this webinar, and I'm very honored to participate in the discussion of such an important topic as women and the return to poverty, which is truly an issue that has to be on all our minds at the moment. We will have our two esteemed panelists. I'd like to introduce them briefly now, and then each one will speak for approximately 15 minutes or so. And I'd ask that you hold your questions and place them in the Q&A feature after that, so that we'll have the Q&A after we've had both presentations. Our panelists, and I'm delighted to be able to introduce them both, are Professor Patricia Camario Mbote. Professor Mbote is a founding research director of the International Environmental Law Research Center and the program director for Africa. She studied law at the University of Nairobi, the University of Warwick, the University of Zimbabwe, and earned her doctorate from Stanford Law School. She is currently a professor of law at the School of Law, University of Nairobi, where she has taught for over 30 years and served as dean. She is an advocate of the High Court of Kenya and was conferred the rank of senior counsel in 2012. Professor Mbote has contributed to policymaking in the areas of environment, land, agriculture, and gender, and was awarded the National Honor in the Order of Elder of the Burning Spear in 2015. She has taught in many universities around the world and published widely. Her latest work, Contending Norms in a Plural Legal System, The Limits of Formal Law, was the basis of her higher doctorate award from the University of Nairobi in 2019. She was awarded an honorary degree in law by the University of Oslo in 2017 for her work cutting across established fields of women's law, natural resources law, human rights law, and development, and was also among 21 women honored by Harvard Law School on International Women's Day 2019 for being powerful voices inspiring change globally. She is a member of the governing board of the IUCN Commission on Environmental Law, a board member of the International Development Law Organization, and the chair of the Association of Environmental Law Lecturers in African Universities. So it's a great privilege to have Professor Camario Mbote with us. Dr. Fidelis Allen, our panelist also, is an associate professor of political science at the University of Port Harcourt in Nigeria and a fellow of the African Polling Institute in Abuja. He served as acting director of the University of Port Harcourt Center for Conflict and Gender Studies from 2015 to 2019. Dr. Allen is the editor-in-chief of the Journal of Political Administrative Studies, Department of Political and Administrative Studies. He is a member of the Midwest Political Science Association of the USA, the Nigeria Political Science Association, the International Political Science Association, and the Editorial Advisory Board Cosmopolitan Civil Societies Journal, among others. Dr. Allen has served as a consultant with the British Council of Nigeria, Women for Women International, as project evaluator and lead researcher for several organizations on projects including the participation of women in policies and governance in Akwa Ibom, Bayelsa, and River State, Nigeria, for SDN. Dr. Allen has contributed over 30 book chapters, published 24 journal articles, authored 4 books, and has been the recipient of multiple awards and scholarships throughout his professional career. Our panelists are extremely distinguished, and it's really not just a pleasure, but with extreme interest that I am looking forward to their remarks on the present day crisis. So with that being said, I'd like to first turn to Professor Camario Mbote to ask her, and then she will be followed by Dr. Allen in their remarks. Thank you.
Thank you very much, Professor Iegas. When I saw women's return to poverty, I actually wondered to myself whether women had left poverty. Because when I look at the context in which we are discussing women's rights in Kenya, it is really not a very encouraging context. Kenya has a gender inequality index value of 0.549, ranking it 137 out of 160 countries in the 2017 index. We have only 23% of parliamentary seats held by women, 29.2% of adult women having reached at least a secondary level of education, compared to 36.6% men. Women account for 48.7% of Kenya's labor force, and actually female labor participation is at 63.6% compared to 69% for men. And also about 64% of female workers work on a full-time basis, and 26% of them work 40 to 48 hours a week. And we have female workers accounting for 62% of all part-time workers, and gender income differentials are actually very rife in the Kenyan context. Beyond that, and I'm just providing the context for discussing where COVID finds Kenyan women, almost half of the 1.3 million micro, small, and medium-sized enterprises in Kenya are owned by women. And 85% of the female-owned micro, small, and medium-sized enterprises are in the informal sectors. So again, while the women provide the bulk of labor in agriculture, they do not own or control land. And many of them actually access land through fiduciary relationships, fathers, husbands, sons. Their access rights are tenuous, because when those relationships are not working, they do not have the rights. And women's land where they own actually tends to be smaller, according to the African Development Bank's studies. So enter COVID. The first case of COVID was confirmed in Kenya in March, and the government took measures to contain the crisis. The responses to this pandemic by the government of Kenya have been dynamic and have been evolving constantly as the pandemic unfolds. The pandemic has impacted normal life and actually had very adverse impacts on all aspects of life: socio-economic, family, education, religion, and politics, as I will explore. And in essence, we are talking about an emerging new normal, or is it a future normal? And even when we talk about a pandemic, is it a pandemic or is it a syndemic, where you have a synergistic epidemic which aggregates concurrent and sequential epidemics or disease clusters? We were already dealing with TB and actually also HIV, the burden for Kenyans generally and Kenyan women has been heavy. Women and girls in Kenya have historically and traditionally faced discrimination on the basis of gender, and COVID-19 is a vulnerability and threat multiplier. It found citizens and women as they were. We were dealing with climate change, extreme weather events like floods. We also had locusts, we had looming hunger, we had the inequality that I've outlined, and then also the struggle to ensure access to socioeconomic rights to education, health, water, and sanitation services. COVID-19 has worsened the situation of women and girls, and the impacts will only be known years into the future. And even though Kenya has obligations under international and regional instruments, as well as the Constitution, to protect and promote women's human rights, the country has been struggling to fulfill those obligations. One of the rife issues is just the rule in the Constitution that not more than 2/3 of the members of any elective or appointive body should be of one gender, and that continues to be elusive. As I pointed out, only 23% of Kenya's parliamentarians are women. So looking at gender and COVID, the UN Secretary General has noted that gender equality, women's rights are essential to getting through the pandemic together, and that faster recovery and building a better future for everyone is going to depend on how we treat gender. When we look then at gender as a social construction of masculinity and femininity, it is influenced by sociocultural attitudes and gender norms, which assign different roles to men and women and translates the roles to power and powerlessness, influencing the capabilities of men and women and what women can be and what they can do. The public-private dichotomy is very gendered. So you have women being engaged a lot in the private space. And even when we talk about the micro, small, and medium enterprises, many of them intersperse the public and private spaces. And women's and men's experiences then of COVID and the responses is shaped by the roles that are ascribed to men and women. And these do not fall into neat categories. There will be conflation of identities, gender, age, disabilities, socioeconomic realities. When we talk about leaving no one behind, there will be those that are already behind, and the COVID pandemic makes them be further behind. The measures that the government has taken to deal with the disease are focused around the disease as opposed to on people. So when you talk about using police to control human behavior, when you focus on the disease instead of on people, then you are less likely to take into account the needs of people, men, women, boys, and girls. The measures are also not gender neutral. They affect men and women, boys, and girls differently. And in essence, then, when we talk about women's return to poverty, you're looking at a context within which women are already behind. So the COVID becomes an issue that complicates their situation. So the kinds of interventions, for instance, the public health interventions on hygiene, quarantine and isolation and social distances are actually gendered. Even the social support measures, because if you talk about food and medicine, the burden on women as caregivers are going to be bigger. Tax measures on pay as you earn and VAT are going to be gendered because most women are in the informal settlement. So even though people get a rebate of pay as you earn taxes, many women will not be in that bracket. And the national hygiene programs that then have greater demands for water means that women's burden of looking for water becomes a lot heavier because of the measures that are in place. And also when we talk about moving justice administration online, then you have to look at access to technology and how that can be gendered as well. And there is also, because of the disease burden, the hospitals are unable to take care of everybody. So there is a lot of home-based care for asymptomatic patients and those with mild symptoms, which increases the burden for women. The closure of schools also means that the burden that women have at home to look after children, as well as to manage their learning, is also a big question. When measures are taken to open the economy, they deal with bigger business. They don't get to the micro and small, medium enterprises. So women really don't benefit. And even the economic stimulus packages and measures, many of them, because they are gender neutral, do not cushion the MSMEs from adverse impacts of the pandemic. In Kenya, we have two levels of government. So we have the national government, and many of the measures I'm talking about have been at the national government level, but we also have the county government, and the county government has been implementing the national government measures, but also passing their own policies to deal with unique situations in the county. They've been putting up health facilities to enable them to cope with the COVID-19 pandemic. And they are also addressing other disasters such as flooding and other disease outbreaks. So these impacts, whether at the national county government, have increased the burden of care work due to the merging of the public and private spheres. They have put a disproportionate burden on women for water and hygiene within the home. They've upset the family equilibrium due to the restriction of movement, working from home, and reduced income. And women have not benefited from the economic stimulus packages and credit guarantee schemes because they are designed in a gender-blind manner that fails to take into account gender impacts of the pandemic. There's also been recorded increases in sexual and gender-based violence, domestic violence, which limits women's economic potential. And there have been clawbacks in the gains made in protecting the rights of the girl child due to increased cases of female genital mutilation, child marriages, early and unplanned pregnancy, which eventually have an impact on girls resuming their studies when schools reopen. There is also the whole question of burial rights, which impact on widows' rights, and also the fact that social spaces are closed denies women the network that they would ordinarily draw on. So what are the challenges then? That there have been no COVID-19 gender response, no specific gender responses to COVID-19, and they have been, the ones taken have been gender blind, and also the limited awareness of the impacts of the pandemic on the genders, which limits the responses that are framed, and also the limited preparedness in addressing gender-specific challenges. So we have knee-jerk responses to the rate, for instance, of teenage pregnancies, and then the limited understanding of masculinity, which has affected the extent to which the specific impacts on men and how those then affect women are addressed. So basically, looking forward, we need the national and county governments to develop and implement gender response mechanisms to the pandemic and pass comprehensive legislation addressing disasters, pandemics, and syndemics. We also need to address gender equality more generally as part of disaster and pandemic syndemic preparedness mechanisms, and the need to report and catalog all the responses for peer learning, so that if one county is doing well, then we can actually learn from it, and even the national government can learn from it. So we also need to address the information that's coming through, ensure that it's gender disaggregated, and also see how we can use technology to support women's economic activities. So what we've learned is that we need innovative research methods to research the lives of women and girls during the COVID-19 pandemic. And feminist research methods are needed to understand the gendered impact of COVID-19, especially taking grounded research methods. And also the importance of increasing understanding about masculinity during and after the COVID-19 pandemic, which will affect the relations between men and women. So I'd like to stop there and hope that the questions or the issues that people want raised can be raised after Alan's presentation.
Thank you. Thank you very, very much, Professor Mbote, for that very comprehensive and detailed analysis of the situation, starting from the fundamental question, did women ever leave poverty? And taking us forward from there. Let me now turn it over to Dr. Allen, please, and then we'll open for questions after that. Dr. Allen.
Thanks very much, Professor Egas and Paulina, for inviting me. I really appreciate this opportunity to be part of discussion of an issue that is so dear to me, which has become part of my core research interest and analysis in recent times. Now, even if more data is needed to fully understand the impact of COVID-19 on women and girls in sub-Saharan Africa, situation report gleaned from media analysis, emerging gray and academic literature suggests unequal impact from individual country policy responses on women and men and threat of women's return to extreme poverty in ways that clearly support previous research. The aim of this presentation is to reflect on the experiences of women during the pandemic, discuss the short-term policy responses and those that need to be taken by the public policy community to address the impact on women and girls in sub-Saharan Africa. Now, the COVID-19 pandemic, which originated in Wuhan, China in December 2019, soon spread to over 216 countries in the world. The European Center for Disease Control and Prevention reports that as of 14 December 2020, the world had recorded over 71 million cases and 1.6 deaths. Out of this number, Africa's share is in the range of 2 million plus cases, with the worst in South Africa, Morocco, Egypt, Ethiopia, and Tunisia. Likewise, it has recorded, Africa has recorded 5,000 plus deaths, with 5 countries reporting most deaths as follows. South Africa, having over 23,000 deaths as of today. Egypt having more than 6,000 deaths. Morocco having more than 6,000 deaths. Tunisia, more than 3,000. And Algeria having about 2,600. In Nigeria, as of 18 December 2020, that's today, a total of 76,000 plus cases have been confirmed, whereas a total of 1,201 have died. In the same vein, Kenya has recorded a total of over 72,000 confirmed cases and more than 1,600 deaths. The United States of America, as of the time of writing, has recorded 17.2 million confirmed cases and 311,000 deaths. Granting fatalities till now have remained unbelievably and comparatively low in sub-Saharan Africa. It seems women and girls are the least to escape severe social, economic, and political effects of the pandemic. The literature highlights the experience of people during past pandemics. For example, the 1918 influenza pandemic, also known as the Spanish flu, stands out. It affected people during the First World War, killing over 50 million people, mainly young men and women, and the militaries involved in the war. The irony is that even the war did not take as much life. Efforts also have been made towards conceptualizing diseases that spread beyond borders through classification. Impact on women and girls from past pandemics such as Ebola, Zika, and other crises have been highlighted in the literature as having stressed economies and worsened pre-existing inequalities. In Africa, as Nantini and Nair found 3,600 maternal, neonatal, and stillbirths resulted from the Ebola pandemic in Sierra Leone alone from 2014 to 2015 because health services were reduced during the pandemic. One aspect of the literature that has stood out is the risk of extreme poverty linked to pandemics. Poverty is used here to refer to a variety of social and economic conditions with indicators of lack and inability of households to access basic personal income, food, shelter, education, healthcare, and so on. To be poor, therefore, can mean a life of hardship. The aim of this presentation, as earlier said, is to reflect on the experiences of women during the pandemic, discuss the short-term policy responses, and those that need to be taken by the public policy community to address the impacts. Now, I want to talk about the experiences of women broadly from the perspective of Africa. As of 30th March 2020, 46 of the 49 countries in sub-Saharan Africa have either fully or partially closed their borders because of the pandemic. A total of 44 countries had responded with social distancing measures, closure of schools, and restricted movements and public gatherings. In Ghana, for example, a mere 3 weeks lockdown caused 27.9% decrease in gross domestic product. Recovery in that country, as with the rest of the countries in Africa, is likely to be very slow for many people. In Nigeria, according to Olaseni et al., apart from a gendered effect in the area of economic insecurity, increased cases of rape and other forms of violence against women and general expansion of inequality across the country have been observed. Olaseni and his co-authors have argued that Nigerians were psychologically distressed from weeks of lockdowns and restrictions. Research conducted by UN Women is one among few with profound findings on the experiences of women and girls during the pandemic. Widening gender and economic inequalities, as noted in this report, is seen through the pathway of socioeconomic effects or impacts on women and girls. They are losing income, facing increased violence at the home front, confronted with increased unpaid care burden, facing challenges concerning health due to risk of shift of funds and services from women reproductive health to combating the pandemic. The report further argues that more than 435 million women and girls will live on less than $1.9 day by day, day to day by 2021, out of which 47 million will be in extreme poverty. Following from this, gender-blind policy responses to the pandemic are likely to reverse progress or gains made in the last 2 decades towards gender equality. Economic effects on women and girls through exposure to poverty in sub-Saharan Africa and the deepening of inequality through different channels, including weak recovery from the loss of income, sexual violence, denial of rights to health, educational and social setbacks, lack of social safety nets, and food insecurity are urgent short-term and long-term policy matters with opportunities to prevent rather than deflate gains already made in the last 22 years with gender inequality. Women and girls are far more prone to loss of income from crisis because of the nature of the labor workforce in Africa. They are mostly in the informal sectors, providing services such as family caregiving, petty trade, smallholder farming, and several others that are not captured in the gross domestic product of countries, let alone record as important for their economic, social, and utility value chains. As country governments across Africa began different lockdown and restriction measures to check the spread of the virus, the majority of those affected almost immediately were women whose livelihoods and family well-being have always depended largely on the daily income they earn from economic activities. The informal sectors, which they mostly find themselves in the quest for economic survival, means that external threats such as pandemics have far-reaching possibilities of making livelihoods much more unpredictable and difficult for women. The pandemic is worsening women's pre-existing poverty and threatening extreme conditions, especially in the developing world. People are affected differently in many ways on the basis of sex, though adequate disaggregated data is still lacking. Intelligent impressions circulating in many quarters based on the emerging data is that the little advances made with regards to changes in the social, economic, and political conditions of women now face a setback, if not a risk of complete reversal. The World Bank has warned that the pandemic will intensify poverty in the developing world amidst an indisputable suggestion that women have been the face of poverty in Africa. By adding 47 million women into the class of the poor and taking the total number of women living in poverty globally to 435 million, the pandemic makes a huge negative impact with Africa as the hardest hit. Across the continent, the pandemic is worsening women's poverty condition in the areas of limited access to economic opportunities, discriminatory government responses to the pandemic. Global economic slump anticipated from the pandemic will have implications for the livelihoods and poverty in Africa. In all of this, sub-Saharan Africa is a melting point. Job and income losses are veritable pathways to increase poverty for women. Studies show they are more likely to lose jobs than men because of inherent gendered employment structure of organizations, with more men in management positions than women. Household economic hardship in the face of lack of social protection for citizens was immediately alarming when restrictions on movements or lockdowns were imposed by governments. Women in the informal sector involved in daily economic activities were caught in the dilemma of financial stress. Based on the reality of Africa's long-held cultural expectations of women contributing to family well-being and the upbringing of children, the disruption in economic activities posed a threat to this role by women. Within the neighboring Alo communities where the University of Port Harcourt, Nigeria is located, women constitute the largest segment of people involved in selling farm produce, and they are reckoned as the most visible on roadside mini businesses. They trade in all kinds of agricultural produce, including banana, granite, plantain, and so on. The period of the lockdown drove them away from the streets. Even lock-up shops in these communities and those in the entire city of Port Harcourt, where I live, extending to villages in all 23 local government areas of River State, were locked down for weeks. In addition, the closure of schools meant that families would stay home, would stay more at home with a tendency to eat more food. Families exhausted food in their homes without a way to replenish, because food preservation is a major problem, even for the poor in urban settings without adequate electricity. At least this was the complaint of some citizens during informal conversations on the impact of the response of government to the pandemic. Radio discussions on the impact of the response of government to the pandemic showed that women and girls had been affected badly by the response of government to the pandemic. Education of children was badly hit, with girls having the widest impact. Some of them are already pregnant and cannot return to school. Schools were the last to be opened in many states in Nigeria several weeks after easing lockdowns and restrictions, even if public gatherings such as weddings and burials have remained controlled. The enforcement of lockdowns and restrictions saw resistance and created tension in some parts of Africa. In Nigeria, Rivers State and the federal government provided palliatives in the form of handout of token foodstuff, which were mostly criticized by the civil society. Not only were the food items grossly inadequate to meet the needy population, there were politicians who hijacked the process and cornered most to themselves, friends, and family members. The NSAS protest in the month of October 2020 exposed many places where government palliatives were hidden and looted by hungry, protesting citizens. The World Bank has argued that dealing with the impact of the pandemic on the price of oil, which the country depends on for national revenues and foreign exchange, and paying attention to pre-existing health crises are crucial for preventing a deepening of poverty. Prior to the outbreak of the pandemic, 4 out of 10 Nigerians lived below the poverty line. Millions are at the risk of poverty. In a similar vein, results of monthly survey on socioeconomic impact of the pandemic for the month of September 2020, conducted by the National Bureau of Statistics, which focused, among others, on indicators of employment situation in household, shows that the pandemic has entrenched pre-existing gender inequality in labor market. The baseline as at 2020, the baseline as at 2018, was 83% for men. On the other hand, it was 72% for women at working age. The survey also disclosed that women are the lowest at economic recovery. This result corroborates previous rounds and reinforces an impression that the share of women working and earning income during the pandemic reduced in favor of men. In the aftermath of the 8-week lockdown in Nigeria, household income fell by a quarter. This led to increase in national poverty rate of 9%. Women were not going to hospitals or health centers for antenatal care because of the pandemic. People have no way to access health services, during the pandemic. The Nigerian Center for Disease Control is in charge of government response to the pandemic. The problem lies with how best to reposition the health system to respond to the challenges posed to Africa by discouraging brain drain among medical personnel and strengthening the system generally in Africa. In the Sahel, Mali, Niger, Burkina Faso, and Chad, closure of border, restriction of movements, poor access to market, and tension over inadequate food in circulation affected livelihoods and had a restive impact on relationship between pastoralists and farmers. Now I want to talk about policy response. Everyone is vulnerable to the pandemic, but the impact of policy response is not equal on people. This reality has been suggested as one way to think about how gender equality can be addressed by governments during the pandemic and in the future. Governments in sub-Saharan Africa were quick to respond in the short term to the crisis with lockdowns, restrictions to movements, travel bans, social distancing, closure of schools and other workplaces, washing of hands and wearing of face masks, and banning of public gatherings to check the spread of the virus. A segment of the literature highlights the impact of all this on women and girls and conclude that these measures did not only affect the aforementioned disproportionately, they were insensitive to their special needs. For example, these authors have argued that social distancing, self-isolation, quarantine, and treatment have psychological outcomes that were not considered in the emergency response to the crisis in the case of Nigeria. The World Health Organization played a crucial role and continues to do so in sensitizing the world with relevant information to correct misconceptions around the behavior of the pandemic and provide policy guide. The declaration of the virus as a pandemic with enormous threat to public health spurred action in many parts of the world. The organization has consistently warned that the impact would have a long-term effect on people, including women and girls, especially in the developing world, as earlier noted. However, the responses, in my view, have been grossly rudimentary and insufficient. In the same vein, UNAIDS has consistently called on governments to respond to the crisis with policies that are not gender blind. Specifically, it identified 6 ways to place gender equality at the center of response to the pandemic. They are the deferring needs of women and girls, particularly those most marginalized, access to essential health services, the neglected epidemic of gender-based violence against women and girls, misuse of criminal and punitive laws, adolescent girls and young girls' education, health and well-being, and valuing women's work and making unpaid care work everybody's work. Addressing the different needs of women and girls, paying specific attention to the marginalized as proposed here, means protecting the rights of women and girls during and after the pandemic. Governments, even those in the developed countries, lack a human rights approach to dealing with gender inequality, providing health services and handling economic insecurity. The pandemic has exposed these inequities, which seems an opportunity to insist on a human rights approach to dealing with these issues. The second principle of ensuring access for women and girls to essential health services is based on the existential structural drivers of inequality. These aspects of misuse, the aspects of misuse and abuse of criminal and punitive laws and education of girls in the face of the pandemic highlighted in view of existing gender inequities, which has become worse under the present COVID-19 pandemic, is equally crucial. School closures and the risk of failure of law enforcement institutions to address with seriousness cases of rape and other forms of gender-based violence have been observed in many African countries, especially in Nigeria. Attention to sexual health and general well-being of young girls took a downward trend as the lockdowns and restrictions persisted. The likelihood of women and girls seeking justice for crimes committed against them by men became unattainable. Rape cases, for example, increased during the period without police interventions. Policy responses are expected to take into full consideration women's work or the already skilled nature of the workforce in favor of men. Women are found mainly in the informal sector, with many private sector organizations and small-scale businesses made to close because of restrictions on movements. Women have been severely affected, which means any policy that overlooks this impact in response to the pandemic is likely to lead to outcomes that further worsen existing unpaid work through caregiving, gender effects of the pandemic on women. Finally, women face increased unpaid work through caregiving in households which pre-existing structures of society discounts. Policy measures in response to the pandemic, therefore, have been suggested to pay attention to these issues to avoid the already changing curve of women's extreme poverty in the continent. Pre-existing gender-based violence has been described as shadow epidemic, which has long been mainly neglected. The pandemic has entrenched it in many countries in sub-Saharan Africa. Reports of women and girls experiencing increased cases of domestic violence and sexual violence in Africa is rife. Although context is significant, response by governments in sub-Saharan Africa seems to have followed some form of similar patterns. Howard Stern's discussion of the strategies, policies, or responses to the pandemic in his article, Africa and the Economic Pathologies of the COVID-19 Pandemic, is an attempt to critique these measures. He explains that it is the systemic conditions inherent in these strategies that have created economic pathologies that ultimately intensified the impact of the pandemic in the developing world, of which Africa belongs. The inference is that due to these measures or policies, emergency measures, the risk of extreme poverty has been heightened. In the same vein, Glover argued that measures including workplace closures and travel bans caused physical, psychological, economic, health, and other forms of harms to groups, including women and girls. I think that there are opportunities, there are lessons to learn from both the pandemic and the way governments in Africa have responded. For example, opportunities for the policy community to radically address the tattered education, health, economic, and social systems from a gender perspective exist for African political elites. Lockdowns, school closure, workplace and travel bans have spawned particular lessons of a need for political elites to address the needs of the education and health systems through adequate funding and inclusiveness that accommodate women and girls. I'd like to conclude by saying that COVID-19 is not the only pandemic that the world has seen, or that Africa has seen. Africa has seen other pandemics. But I would like to say that for the first time, we have seen a pandemic that is so wide-ranging in terms of geographical reach. So which means that some kind of multilateral approach to addressing the problem is crucial. And here I'd like to say that the World Health Organization, the African Union, and other regional groups need to be able to do more in terms of preparing for the future, because we never know when the next pandemic will break out. Thank you very much.
Thank you very, very much, Dr. Allen. And thank you again, Professor Mboto, for these two extraordinary presentations, which I think lead us, frankly, to focus on the impacts of policies very directly, rather than just to understand the crisis that we're facing as a policy crisis, as much as it is a health crisis. Because I think that you've both underscored the distorting effects and the inequitable effects of policies that are A, not sufficiently targeted to gender inequalities, and basically move as if a gender neutral world could be imagined, evoked as the sort of background of policy in this area. So with that being said, I'd like to open the floor to questions from the audience. I would like to ask both of you, if we take the policy response itself to be the real object of our concern, then what do you think explains the deficiencies of the policies and their lack of sensitivity to the gender dimensions of the effects that they were of the policy makers? The sort of, why have we had a response that has so many responses that have been so, one could almost say, blind to the inequities that they themselves were generating?
Okay. You want me? Can I respond?
Please.
Yeah. My paper is very clear on the issue of policy response. Now, for most countries in Africa, the pre-existing shortcomings with limited infrastructure investments in the health sector did not support the emergency responses that were made. Now, when countries don't take time, over a long period to plan for the health system, for their health systems, pandemics would create chaotic situations that will make it impossible for whatever emergency response to work. For example, most Nigerian politicians like to travel overseas for medical attention. That's a clear indication that there's no faith in the Nigerian health system, which also means that much has not been invested in terms of equipment, in terms of infrastructure, in terms of human resources. So the emergency responses that came were produce outcomes that could not address special needs. For example, pregnant women, those suffering from HIV/AIDS, those with problems of high blood pressure, so many people with all kinds of sicknesses and diseases were trapped, and some of them died because they really couldn't access hospitals. And there was a lot of fear in the air because it was difficult for anyone to expect that he or she could be attended to, in a convenient and comfortable way at the hospital during the heat of the crisis. And so you'll find people dying in their homes. So now what government needed to do, in my view, while responding to the crisis, the health crisis, there was need for government not to be blind to the special needs that existed at the time. We really can't say the number of people that died because their needs were not met at the time, because everyone was talking about the pandemic. And the political elite was the most fearful, I can say that. They were the most fearful, and some of them had personal doctors anyway. So it was the poor that suffered. So it's about policy, because when you look at women, the number of women, if you look at the statistics, though we don't have adequate statistics right now, but women have been less infected by the pandemic. In Nigeria, 53% of the men were affected, which is to say that more men were affected, men were more affected than the women. So, but everyone can be affected. That is very clear. Anyone can be affected. The issue is addressing the special needs of people, and women and girls. I visited some communities in northern Nigeria, a rural community in northern Nigeria. I can tell you that those in the rural areas were almost forgotten, because as far as they were concerned, there was nowhere to run to. And really, the evidence that the pandemic was, even in those communities, was almost not there. So people were living well, living fine. But they couldn't go to the hospitals because the talk of the pandemic was everywhere. And the fear of being diagnosed as having the pandemic was also there. And this is because their special needs were not attended to. Women attempted to deliver in their homes, and some of them died, because it's difficult to deliver in your home without special medical attention. So why it is important to address the threat of the pandemic, it was even more important to address the other diseases that people had. So people had special needs that were not considered.
I understand. Thank you. So I guess that, the question is that the pandemic has laid bare and exacerbated underlying inequalities, including in relation to the capacity to influence policy. And that's a dimension that we have to take into account, so that, because none of these effects are naturalistic, right? It didn't have to be this way. Yeah. And there was lots that was already known that could have led to different guidelines for policies. And I'm not talking necessarily only about the African countries. I mean, this is true generally. One could say, in general, the pandemic has laid bare inequalities, and the policy responses have exacerbated, in so many cases, inequalities. And the real question is, why did that happen? Why did we have those kinds of policy responses, and what has gone in the other direction? Where have policies that were more protective and more supportive of gender equality been enacted? It seems to me. But we have two questions that I'd like to open for. So the first is from, and please forgive me if I mispronounce names, David Wanalgo, who asks, there is a plethora of policies regarding stemming the tide of women in poverty in Africa. However, it appears that translating policies to action is a problem. The Kenyan affirmative constitutional provision for parity in elective office is a case in point. How do we bridge the gap between policy and practice? And perhaps I would ask Professor Mbote if you would like to be the first to answer that question.
Yes, I think the gap between policy and practice is real. And I'd just like to say a little bit about the question you asked before about why were the policy responses not on point? And I think there's a couple of reasons. One is the unpreparedness. I think I talked about the COVID-19 as a threat multiplier, that it finds people the way they are, it finds systems the way they are. And so if your health systems were struggling to reach everybody, then they're going to struggle even more. And it's the same with the right to water. I mean, many of our, like in Kenya, I won't speak about the entire Africa because I've done research in Eastern and Southern Africa, that the right to water and sanitation is still something that hasn't been met. So when a pandemic comes, a pandemic that actually requires water, then the interlinkage between water, sanitation, and health is real. And that leads to the third problem, which is the silo approach to policy making, that we never really look at the interconnectedness of different policies. So the platitudes, and this now brings me to the policy to practice, the platitudes that we have in policies. Kenya has a very robust gender policy. It has a very robust constitutional provisions. So, I mean, like our Article 27 on equality is transformative. So when a state is under the duty to promote, to respect, to fulfill human rights, but is unable to, and you know, this is the situation of very many governments, that they find themselves not able to meet the basic requirements for their citizenry, then you sometimes have other actors coming in, humanitarian organizations, private actors, charity. But at the end of the day, policy to practice calls for governments being serious in costing. What will it cost to get policy X to be implemented? Because if we don't do that, then it's going to be papers on the shelf, but people will not really enjoy the rights that are guaranteed them, or the policy provisions will not bear any fruit for the citizenry.
Yeah, let me also say one or two things in response to the question on the gap between policy and practice. I think many countries in Africa are already working to see that, formally speaking, legally speaking, that women and girls do not have hindrances to the protection of their rights. Even in Nigeria, there's no longer a situation where you find that there are no laws. Nigeria has several instruments now to protecting the rights of women and girls. But I think the issue is partly about those involved as members of the policy community. Now, policy implementation, or ensuring that policies are implemented, enforced, is a duty that every member or actor in the policy community should be conscious of, which is to say that the policy community, which includes the civil society, include scholars, include the political elite and different agencies and ministries saddled with responsibilities of protecting the rights of women and girls, have to be seen to be working. You know, so I think it's about time the civil society did more than it has been doing concerning protection of rights of women and girls. Now, for COVID-19, I have not seen much happening from the side of the civil society in terms of identifying key issues with emergency responses of government. I've not seen much happening from that angle. So, because policies don't just produce the outcomes that are expected, something has to be done. You know, the point of formulation to the point of implementation and achievement of objectives, a lot has to be happening. And that is not happening very well now because, for example, like I said, the civil society needs to be able to understand and critique, you know, constructively some of these measures, emergency measures. So I think bridging the gap between policy and practice would not just mean that those who formulated the policy are the same people who should make it work. Yes, they are very important, but often policymakers may be reserved if no pressure is coming on them to do the right thing. You know, so and when you talk about the policy community, it's not about those who are in formal governmental positions alone. But those who are outside the formal governmental settings are even more crucial, you know, in terms of making policies work, maybe reforming policies. So I think for me, a lot has to happen, you know, in order to bridge that gap.
Thank you very much. I think that the emphasis on policy communities and sort of taking more of an issue network kind of view, and seeing the complexity and the multiplicity of actors who have to kick in in order to translate a declared policy objective into, in fact, a practice is really key. We have another question from an anonymous attendee who says, "Thank you for your excellent presentations. I would like to ask both of our distinguished speakers what their recommendations would be for the types of advocacy that would be most effective at a local community level. What role is there for a rural private health center to contribute towards positive change?" That's
I think
really
one of
to be
the
very
areas
specific.
where we have many, like in Kenya, one of the broken down systems is public health systems. For the longest time, there used to be community health workers. And with community health workers, they were not just concerned with cure, they were concerned with prevention of disease and actually intervened in households to ensure that people didn't have disease vectors in the homestead, and would actually enforce particular mechanisms to ensure that people live in particular ways. So I think empowering local people at the household levels, and you know, that again comes to empowering women, because as I had talked earlier about the public-private divide, women tend to be very engaged in the private, and that private reproductive is usually shielded from the public, but it subsidizes the public quite a lot. So if there are not enough interventions in the household level, you're going to have more people presenting sick. And so empowering women is probably one of the interventions. Communities, local level, but women, because women deal with the care burden, the nurture burden, the looking for water, if you're talking about nutrition. So for me, that is one of the areas that I'd say. And then, of course, investing in community health workers, so that people aren't just looking for health centers, they have solutions within the community, and they actually do more of prevention than curative.
Okay, for me, COVID-19 pandemic has shown that health crisis is so strongly connected to every other aspect of life. When diseases spread beyond borders, they easily affect every aspect of life: economy, travel, leisure, tourism, name them. So, and this happens at all levels of society, from the international to the local level. So for me, it's important to begin to frame human rights issues from, or to frame these health issues from a human rights perspective. Because, like I said, health issues are not, even the government, across the world, do not strongly see them as human rights issues. But what has happened now means that it's high time we began to frame health problems as human rights problems. So at the local level, civil society should begin to articulate, frame their advocacy activities, begin to see the problems of people, see the connection between health matters and every other aspect of life, livelihoods, economy, environment. Somehow they are all closely connected. So, but how do we effectively frame these issues, bringing them all together? It's something that we need to start doing. Health problems are human rights problems, and we need to begin to see this connection.
So I don't think we have any more questions from the audience, but it seems to me that this issue of how we frame the entire problem and whether a human rights perspective that you're both, I think, sensitive to and have worked on, how a human rights perspective could actually help to inform a different approach to policies here. And because I work on human rights also, I guess, I think is really crucial. It seems to me that if one could start thinking about the policies to be implemented from a human rights perspective, then that could lead to very different outcomes. And that the issues that you would have then would be reconciling human rights perspectives in relation to women and girls with human rights perspectives more generally, and how you would bring those two together. But I think that I'm asking whether you would agree that that would be a step forward, actually.
I actually
Sure.
agree. I agree.
Yeah, I agree. Yeah.
Yes. So the next question is whether we're going to enter a moment which is better for human rights than the past several years have been, in terms of the capacity to develop an incisive discourse and set of policies. But we have a question from Victoria Azu, who says, as Dr. Allen rightly observed, people in some rural areas seem forgotten. What policy recommendation is given to create awareness that enable those classes of persons to benefit from government policies? This is from Dr. Victoria Azu from the University of Port Harcourt in Nigeria.
I'd like to respond to that from our perspective here, because I pointed out that we have two levels of government, the national government and the county government. And actually health is a devolved function. So empowering the county governments to develop facilities at the county level is a way of ensuring that people at in rural areas are not neglected. I think now we are moving away from the situation where everybody looked at the capital city as where they got health care. And the aim is actually to have each county have a referral hospital. And actually, as part of the responses, each county was required to prepare to handle COVID-19 cases so that people don't have to travel across boundaries. It is a work in progress, but with the amount of monies that are allocated for health going to the county levels, I think we're going to not have neglect of rural areas. People may even be coming from the cities to go to the rural areas if there is better healthcare available in the rural areas.
Yeah. Yes, that would be, that's an interesting possibility, I think, to raise. Dr. Allen?
I think Nigeria has a national health policy. I think it's skewed in favor of the working class. Although everyone should be able to enroll with that policy, but not everyone has the opportunity to do so. So many people, especially in the rural areas, do not even know that such a policy exists. So I think the majority of Nigerians are outside that policy, which is to say they are not benefiting. Now, there are health centers in Nigeria. The local governments, the state governments, and the federal governments all have a way of making contributions towards providing health services in this country. But I think health matters have not been taken very seriously. Those are the apex of governance. Those are the top, have a way of sending messages to Nigerians that these health centers are not for a class of people, which is to say that the health centers and the hospitals are meant for some persons and not for others, which is why they can always want to leave the country, come to the US, go to Dubai, go to India, go to Europe for medical attention. So what that does to the health system in Nigeria is that often people have an impression that these hospitals do not have what they need to be able to provide the kind of services that they should be providing. And we have seen Nigerian medical personnel wanting to migrate. Many of them may want to migrate if they have such opportunities. Why? Because they think the home front is not providing the environment for them to practice medicine effectively and get properly remunerated. So I think these are issues. I'm just wondering if it's not high time we started to advocate, we started to encourage the civil society to see the health sector as the cornerstone of development of this country. But I want to say that what UNAIDS has identified is 6 areas that UNAID has identified as crucial for maintaining gender equality in responses to the pandemic. Remains valid for every country. These issues they've identified are crucial, important for every policy for every country's policy, you know, in my view. So from that angle, but I'm wondering to what extent can multilateral settings, environments, ensure that countries, individual countries, are responding to these policy advice provided by them? I'm really wondering to what extent.
I'd like to just one point, Professor Eggers. You know, Dr. Allen has talked about people going to Dubai, people going to India. I see COVID-19 as an equalizer, because when when people couldn't fly out, people had to really go to hospital where they were, because they couldn't travel to India, they couldn't travel to Dubai, they had to stay where they were. And in Kenya, what we are now discussing is what people call skin in the game. So if you are a public officer, you are not allowed to access, and you're sick, your entitlement is to go to the health services that you oversee, or take your children to the schools, if you're minister for education, that you oversee. So they can't be good for you to oversee, but not good for you to patronize.
So let me ask a question about that, because I think this is a really important point, which is the capacity of elites to escape the mechanisms that they have the responsibility to implement on behalf of the societies. And so my question is it in Kenya, and I think that's such an important issue now, the question of skin in the game, is it that you won't get public support, you won't have reimbursements, you won't have public subsidies, you won't have whatever, if you go outside of the system? Or is it that there's actually some kind of limitation which says we're really going to, because I mean, then that would raise a whole series of other problems. If you're saying to people, you're not allowed to go outside of the public system.
I think what has happened is that this is something that's being discussed, but what has happened is you get COVID-19, if you're the governor of a county, it finds you where you are. So if you have not invested in your county to put in place the facilities, we have had quite a number of public officers die in their spaces. And I think these sort of highlights the need to have hospitals. One of the silver lining of COVID-19 is that the government has now put money aside to develop a huge state-of-the-art referral facility for cancer, and also for outside what was there, to have one for COVID-19. But it may be that you still have money to go, but the time you spend between getting sick and getting to India or wherever, you would have expired. So everybody now is under pressure to ensure where they are, there are facilities.
Yeah, I think that is an extraordinary development that I'm not sure, living in a country like the United States, I would have really imagined, although probably I should have. I mean, but that is that the incentives for elites to actually invest in the local public systems, in particular in relation to health, have really been increased significantly. Mm-hmm. That I think is, that's an unexpected consequence for me, at least. That that's very significant, potentially. Okay. I think that we're running out of time, or may already be out of time. So I just want to thank both our speakers so much for a very candid, deep, and interesting conversation that has led us down many different paths, from the exploration of the ways in which COVID revealed underlying inequalities, to the emphasis on the ways in which the policy responses have exacerbated those underlying inequalities, and to some of the unexpected consequences also of the pandemic. So with that, I would like to thank everybody who's participated. I would very much like to thank Pauline and Joelle and the Columbia Global Centers for hosting this discussion. And of course, I really, really want to thank Professor Mbote and Dr. Allen for participating, for giving us such wonderful presentations, and for stimulating a really great conversation. I very much hope that we will be able to continue this discussion, and that we will at some point in the not too distant future be able to ask ourselves, so in the last 6 months from now, would we be giving the same presentations? Would the data look the same? Would our analysis of policy be the same? I think maybe we can try to put that on the agenda as a follow-up conversation.
Okay. Yeah.
Thank you all so much.
Thank you too.
Yeah, thank you so much. Thank you.
Okay, bye.